Good afternoon, everybody. Welcome to our Monday afternoon Instagram live chat. And it's Dr. Michael Jacobs here at the Fertility and IVF Center in Miami. Today's topic is very timely, and it's entitled How to Get Pregnant When I'm Gay. And this is important to both men and women who happen to choose a same-sex relationship. So if we look at the topic in general, obviously we need to distinguish, are we talking about two women that are together as a couple, or two men together as a couple, or even a single woman or a single guy, of how do I create a family, and so forth. So let's start with the women's side first. Two women having a child together brings up a lot of interesting opportunity. The big advantage on the women's relationship is that we're dealing with two people with two sets of ovaries and two uteruses, and that certainly brings up a lot of combinations. So in general, to get pregnant in any circumstance, we need a source of sperm, a source of eggs, and a uterus that's normal, that can carry a healthy pregnancy and give birth. And so in a female-female relationship, the first question is who wants to be pregnant, which member of the couple wants to be pregnant, basically. And then that answers the question usually as to whose uterus we're going to use. And then the issue is where does the sperm come from? And that's usually a sperm donor. The simplest way of approaching where do we get a sperm donor from is to use a sperm bank, basically. With sperm bank sperm donation, it's anonymous. The donors have donated sperm. They've been thoroughly vetted by the sperm banks for good quality sperm, for their medical histories, for their psychological histories, and usually, and the sperm has been infectious disease screened and quarantined for 6 months before it's released. So the advantages of a sperm bank as a source of sperm is we've got good quality sperm that's been vetted for infectious disease, and it's an anonymous situation. In certain circumstances, we can certainly consider a designated donor of somebody the couple knows. In that case, we still want to go through the psychological screening of the donor, infectious disease screening of the donor, and whether or not we want to quarantine the sperm for a period of time and retest the donor before releasing it. So the simplest approach is use sperm from a sperm bank. There are multiple sperm banks available to choose from. The most common one that we use is California Cryobank, but you can use the one in Fairfax, Virginia, and 2 or 3 other ones. And our office is happy to give you a list of the sperm banks that we've had relationships with that are available for you to peruse their donor profile base and select a donor. So the donor comes from a sperm bank. Usually one of the two members of the couple will be the host of the pregnancy and deliver the baby. And the question comes is whose eggs to use. Now the simplest approach, most couples, usually one member of the couple is more likely to want to give birth than the other, and certainly that defines things. The simplest approach to getting pregnant is just doing intrauterine insemination with donor sperm. As long as, let's call it partner A in this female-to-female relationship has good quality eggs and potentially can ovulate, then usually we will use a mild ovulatory drug like Clomid or Letrozole to help time when it's best to inseminate, and in the middle of the cycle when ovulation is taking place, to take the donor sperm and do intrauterine insemination with donor sperm. And in a cycle where you are inseminated with donor sperm, assuming everything else is relatively normal, you take on the same success rate that you would as if you were having a relationship with a guy in the more traditional sense. And in women that are under 35, that's around 20% per cycle. In women 41 and 42, it's going to be about 10% per cycle. So, and let's just say overall for women under age 40, we should have a 15 to 20% pregnancy rate per cycle that we inseminate, which is a normal pregnancy rate. And what that means is that it might work the first time, or it may take 3 or 4 cycles to get it to work. We don't get too bent out of shape if it doesn't happen the first month or the second month, as long as all of the ovulatory parameters are normal. If you're ovulating, we're inseminating at the correct time, the lining of the uterus is developing normally, and we've done some preliminary testing to make sure that the tubes are open and there's no hidden disease present, then we should see these optimal pregnancy rates and hopefully get people pregnant relatively quickly. We've had couples where partner A gets pregnant, and then a year or two later, partner B will say, okay, they want to get pregnant and use the same sperm donor. That's not a problem at all. We do recommend that once you do get pregnant with this particular sperm donor and you desire to have a second child, whether it's to be in the same person or with your female partner, to contact the sperm bank where you got the sperm from and reserve a reasonable number of samples of sperm so that it's available for the future with your use. The sperm banks are pretty good, and if you reserve the sperm and leave the sperm at the sperm bank for safekeeping, most of them will, even if you change your mind, as long as the sperm has never left their facility, they'll buy the sperm back for you, less a small amount of money for the handling of the sperm or just having it kept in their facility and so forth. But once you take the sperm out of their facility, they won't take it back because they don't want any risk that for any reason somehow it got mixed up somewhere down the road. So, option one, very simple. We define when ovulation is occurring. Most commonly, we'll use a ovulatory drug to help get that to happen, and then inseminate with intrauterine insemination using donor sperm in the middle of the cycle. Wait 2 weeks, find out if you're pregnant or not. If you are, terrific. If you're not, do another cycle. If we can fine-tune something in the second or third cycle to make it work a little better, we'll do that to maximize your chance of getting pregnant. The second approach, which many of our couples have done, is that they want to have a child, but they want more of an intimate contact with the other, with their partner in the process. And what we've done is in vitro fertilization, where let's assume we're going to use the egg from partner A and the uterus in partner B. So obviously, if partner A didn't have a uterus, was incapable of carrying a pregnancy for either because of previous surgery or some medical problem, you can easily take the eggs from partner A, fertilize it with the donor sperm in a dish, grow the embryos out. If we're doing IVF, you have the added advantage of doing pre-implantation genetic testing for aneuploidy of the embryos to make sure they're genetically competent, and then put that embryo into partner B in a programmed cycle. So in this case, we're using a donor sperm, your partner's eggs, and your own uterus. And we've had some patients flip this on its reverse, and we've had some couples where initially we'll take partner's A egg and fertilize it with the donor sperm, put it in partner B will deliver a baby, then it'll come back a year or two later, we'll take partner's B egg, fertilize it by the same donor, and put the embryos into partner's A, which is kind of a cool, nice thing of having the ability to give birth to each other's child and flip that. We've had other couples where one member of the two female couple doesn't want to have any interest in giving birth at all, and that's okay too. And again, we have the options of using your own egg with insemination. If for some reason that doesn't work, or there's tubal blockage or anatomic disease like moderate to severe endometriosis or scar tissue present inside that would make that not likely to happen, then going more quickly to in vitro fertilization, where we can fertilize the eggs in a dish, is a good viable option to just doing inseminations. If the couples together, whether you're two females using donor sperm, a single woman using donor sperm, or even if you're a more traditional couple, a heterosexual couple, a male and female couple using donor sperm, the American Society of Reproductive Medicine recommends that any couple using third-party reproduction, this meaning donor egg, donor sperm, or a gestational carrier uterus, have at least one session with a psychologist to go over the whole issue of using a donor in this case. So, if you're a female couple and we're using donor sperm to get you pregnant, we're not asking you to go see a psychologist because you've chosen a female partner. We're asking you to see a psychologist because we're using donor sperm, and that would be the same as if you had a male partner or a female partner. So that's just standard procedure. That person's a great resource as well to help answer any questions that you've had. The psychologists have worked with our practice for 20 plus years and have tons of experience with other patients and can answer a whole lot of questions. From a practical side, once sperm is donated, it no longer belongs to the donor. It belongs to you. The baby that results is your baby. No one can come and take it away, and so there aren't any real issues there. The important thing is that donor sperm is screened appropriately for infectious diseases and that we get good quality sperm. On the male side, it gets a little more complicated because of the three things that we spoke about, meaning needing eggs, needing a source of sperm, and needing a uterus. Whereas if we have a female-female couple, obviously we've got two options of where to get eggs from and two options of where to put the embryos. We don't have any sperm, and that's easily solved with a sperm donor. In either a single male situation or a male-to-male couple, we've got two sources of sperm. That's nice, but we're lacking the other two entities as far as we need a source of eggs and we need an uterus to put them into. And the important thing here from a practical side is that we want the source of the eggs and the uterus to not be in the same person. And that's very important because in order to have a male couple have a child, we need to do in vitro fertilization. We need to fertilize eggs in a dish with sperm, create embryos, and then transfer those embryos into a uterus. And the uterus is a gestational carrier. And the reason that you want the source of the egg and the uterus to not be the same person is that we want to distinguish a true gestational carrier from one that has any biologic involvement with the fetus that they're giving birth to. We don't want to do what's called true surrogacy. It's not a true or false question, but true surrogacy refers to the fact that let's say we were contracting with a woman to inseminate her with your sperm. She would get pregnant, and then 9 months later, when she delivered the baby, she would give that baby to you. That's more of an adoption scenario, and it's got a lot of complications legally that I would defer to the reproductive attorneys on that can address those questions. But the simplest way to evolve all the issues that brings up with whose baby is it, who has the right to the baby, what if she changes her mind, if she changes her mind, am I stuck paying for paternity care because I'm the father of that baby, now I can't get that baby. This was the baby, quote, the baby M scenario in New Jersey, 20-something years ago. And because of that, we avoid that 100% of the time. So the way to do that is to use a gestational carrier to carry the pregnancy. Gestational carriers can be somebody you know, or somebody you recruit, or someone that you recruit through an agency. And just as for many years there were adoption agencies, nowadays there are agencies that specialize in recruiting egg donors, recruiting gestational carriers, and we would highly recommend using one of the agencies to help recruit a gestational carrier. Many of them have their own in-house reproductive law people that can assist you in any legal questions and the contracts that are involved. But as long as the gestational carrier has no biologic relationship with the baby that she's carrying, she doesn't have any rights to that child, basically. So that's the big advantage of using a gestational carrier. Now, a little part of this is tricky in that it's very important that when you contract with a gestational carrier that you know the person, that you don't have to have daily interactions with them, but you've met them, you're comfortable with them, and that you have some relationship with them during the pregnancy because they're carrying your child, basically. From our standpoint, what the reproductive attorneys and the courts are going to look to is a document, an affidavit, basically, that says the biology of the embryo is what it is, and it's not related to the gestational carrier. And the second, as a result of that, you have the ability to ask a judge to seal the initial birth certificate and then issue a new birth certificate not related to the gestational carrier in your names. So the baby belongs to you, but you need to have a very understanding relationship with the gestational carrier, because what happens during that pregnancy is going to be based on the gestational carrier. You can't dictate to that individual what decision they're going to make. So you need to make sure that you're on the same wavelength as the gestational carrier with things of, what happens if there's a fetal anomaly, which would be a rare thing, but let's say it's there and something that wasn't genetically diagnosed ahead of time, and it's a spontaneous mutation. Do you terminate a pregnancy? Do you not terminate a pregnancy? You can't force somebody to do something. It's not your body, it's their body. So you need to have a good general understanding of your basic beliefs and their basic beliefs. Similarly, with what happens if there's high order multiple pregnancies, do you do selective reduction? Obviously, we try and limit the number of embryos going back to minimize that risk to all concerned. So gestational carrier has no biologic relationship with the child. It's important to have a relationship with the intended parents so that there's a mutual understanding of what you're going to do in certain circumstances, so that you're all on the same wavelength together. You're supporting the gestational carrier emotionally and guiding the care of the baby, and at the same time you have an agreement and philosophy going into the thing of how you believe, so that it minimizes the chance of having a big problem later. When it comes time to birth, the attorneys will have the appropriate paperwork set aside so that when the baby is born, everything kind of changes in that, the gestational carrier has control of that pregnancy because she's the one pregnant. But once that baby comes out of the birth canal, if it's a vaginal delivery or it's a cesarean section delivery, you as the intended parents become the custodian of that child legally, and it's your decision what happens. And most of the time this is a paperwork thing and it's not any major issue, but if at the time of delivery there was some emergency that and parental consent was needed in order to do something to the baby, then it's important that the legal paperwork be there, because as the parent this baby is now born, you are the parent of this child, and you need to have and accept that responsibility and be in charge of that child. So from a practical side, obviously any male couple is going to need a gestational carrier. And again, it can be somebody you know, somebody you don't know initially, but will get to know. And the important thing from the gestational carrier standpoint is that it's somebody who agrees with your general philosophy on the pregnancy and how you're going to manage certain things that may occur in the pregnancy. And two, that from our standpoint medically, that this gestational carrier have a normal uterus, so they have a good chance of implanting an embryo and successfully carrying to term a baby, basically. And three, they have no medical, psychological, or drug abuse, infectious disease history that would prevent us from using the carrier safely in this situation. The sperm obviously is easy. If you're a male couple, then one of you has to provide some sperm. And the third element to this is obviously the eggs. And eggs, again, can come from two different sources here. When you're looking at donor eggs, you can choose eggs from a designated individual or eggs from an egg cryobank. And there are pros and cons to both. Eggs that you get from an egg bank, the egg banks usually limit you. Eggs from an egg bank are, you get 6 or 8 eggs only. And in a normal circumstance, if we were dealing with a woman couple or a male-female couple, and we were using eggs from an egg bank, 6 eggs or 8 eggs would probably be sufficient to get one good embryo out of and a decent chance of getting pregnant. But if you're going to go through the whole process of contracting with a gestational surrogate to carry a pregnancy and all that, you'd hate to go through this whole process and find out from the 6 eggs you got from an egg bank that none of them were normal, or that you only had one shot at getting it to work. So in this situation with a male-male couple using a gestational carrier, you're probably going to be a lot better off considering using a designated egg donor. With a designated egg donor, we're taking a woman preferably under the age of 30, stimulating them with injectable fertility eggs to produce 10 or 20 eggs. We aim for 15 to 20. We've gotten as few as 5 and as many as 35, depending on the individual's response. And then if we have, 15 eggs, let's say, of good quality, it just gives us a lot more eggs to work with, to fertilize sperm with, grow embryos, and on the 5th or 6th day of development, if the decision is to consider biopsying those embryos by doing pre-implantation genetic testing, we can biopsy the cells around the outside of the embryo, send it to see if it has the correct number of chromosomes, and if it's a competent embryo genetically, that would be an embryo that would be available to transfer. The other major advantage of using a designated egg donor, particularly in a gay male-male relationship, is that if we have more eggs, it gives us the option of fertilizing half the eggs with one partner's sperm and half the eggs with the other partner's sperm. And in contrast, if we have 2 women together, we've got to do 2 separate egg retrievals, which is fine, but it's a lot more complicated, a lot more expensive than in a situation of getting a sperm sample, obviously. And in that case, if we have a good batch of eggs, we can divide them in half and inseminate half the eggs with partner A sperm and half the eggs with partner B sperm, let the embryos grow. If we're going to biopsy them, make sure they're normal, check the genders, and then ideally we still recommend a single embryo transfer in any couple to put one embryo back, and then after a couple years later we can go put the other embryo back from the other member of the couple. We've had some cases, particularly in this situation, where we kind of let our arm being twisted to transfer 2 embryos, in which case we would transfer a combination of one from each partner. The problem is that it doesn't guarantee 2 embryos are going to stick. And when you look at success rates with embryo transfer, even with a biopsy normal embryo, we're looking at 50 to 60% success rate with 1 embryo going back. You would think, okay, we put 2 back, you get twice the result. Unfortunately, you put 2 back, you go from, let's say, 50% to 70% or 75%, but it doesn't go to 100%. And the multiple risk, even with 2 embryos going back, is only 40%. So you get the most babies born in IVF going 1 at a time. You have the least number of obstetrical complications 1 at a time. If you're going to put 2 back, it doesn't guarantee that we're going to get any. It increases the likelihood of something sticking in a cycle, but it doesn't mean you're going to get twins. We do recommend, at least I personally recommend, that if you do put embryos back that come from a mixed genetic background, meaning the sperm were from different partners, that you do some testing at some point to know where the baby came from. This is really important for the child to know their medical heritage, their medical history, and also if the goal is to have 2 children, 1 from each father, basically in this case, you need to know which one was the first one, so we know whose embryos to put back the second time. So for those multiple reasons, it's important to get those questions answered and figured out. If we're using third-party reproduction, same thing with, in this case, because we're using a gestational carrier and because we're using a donor egg, we do need psychological screening to be performed based on the American Society of Reproductive Medicine's recommendations. The egg donors need to be screened for infectious disease. They need to be screened for ovarian reserve, and they need to be screened for drug abuse and so forth. They need to be psychologically screened. From a standpoint of how good are their eggs, it's no different than with any patient. One of the questions somebody asked is, what about an AMH, anti-Müllerian hormone level of 0.2 or something, or 0.3? A normal AMH level for an egg donor should be at least 2.0 or higher. In our program, if it's not, we would only consider using somebody with a lower AMH level if it was a designated donor and everybody understood that our expectation as far as the number and quality and quantity of eggs would be less in that case. But in general, in an infertility population, AMH is very useful in helping us determine how much fertility drug to use to stimulate the ovary, and it gives us a range of what to expect as far as the ovarian reserve of that patient. And obviously, if we're looking for egg donors, we want egg donors that are fertile, that have good ovarian reserve, that are going to respond well to fertility drugs and make more eggs with less drug, because it's more cost effective for you guys in that sense than the other way around. So, the egg donors need to be screened medically for infectious diseases, for ovarian reserve. We want to make sure they're reliable, they show up to the office, they do what we're asking them to, and that we're going to get good quality eggs. The gestational carrier, you have the added burden of making sure that you and the gestational carrier are on the same wavelength with basic philosophy. If we put 2 embryos back, what happens if you get 3? That's why another reason we don't like transferring more than 1, because even with 1 embryo going back, there's about a 3% chance, 2 to 3%, that embryo can split and you wind up with 2. And twin pregnancies are more complicated, but triplet and quadruplet pregnancies are pretty much a disaster with severe prematurity and complications of prematurity. It's important to have a legal contract with the gestational carrier. Egg donor is indirect in that, in essence, if you're using an agency, they'll have a contract drawn up for if you're using one of our donors that we recruit in our center. What we try and do is have the donor donate the eggs to the center, and then we're giving you all the eggs that we get from that donor. So whatever eggs we get from that cycle of treatment belong to you. We recommend fertilizing all those eggs with your sperm or a combination of the two men to have more diversity in the embryos. The rest is just straightforward IVF. Get eggs, fertilize them, develop embryos, check them to make sure that they're genetically competent, and then select the best embryo to put back into the gestational carrier. Same process that would be used if we had two women together, where we were using eggs from partner A, a donor sperm, and putting the embryos into partner B. The embryos are transferred using what's called a programmed cycle, where we turn off the natural hormones and replace it with estrogen and then subsequently progesterone to simulate what happens normally. And with that, we try and create as normal environment for the embryo as possible, and as a result of that, have the good high pregnancy rates that we're accustomed to. So that's pretty much the whole story. The good news is that we've been doing this for many, many years now. We have a lot of experience dealing with the LTGDB community, and look forward to working with all of our patients of their diverse backgrounds and needs to help them have a family and help them create the baby that's going to, and the family that they want going forward. So thank you for tuning in. Every Monday at 12:30, I have a chat on a topic related to what we do that affects some, if not many, of our patients, and look forward to having you join in at your leisure when you can. If you have specific topics that you would like me to address, please just email them to our office, and we'll be happy to try and incorporate them in the next few weeks. So have a good afternoon, everybody. Stay safe, and we enjoy taking care of you, and we very much enjoy seeing the result of your hard work coming true and having a baby. Have a good afternoon and stay safe.